So let's look into the data and legal side of nursing. So first we'll do validating and documenting the data. So validating data, this is when we're double checking or confirming the accuracy, completeness, and reliability of the information that we're obtaining in our subjective and our objective data. So why do we need to perform this validation? It's to ensure data is accurate and factual. It also ensures that we're avoiding incorrect conclusions or inappropriate nursing diagnoses based on faulty data. We also want to do validation to clarify any discrepancies between the patient says and what you observe and even what other data may show. And then it also helps us improve clinical judgment and patient safety. So when do we validate? Whenever there is doubt, inconsistency, or missing information in your assessment. And then validation is to occur when, one, data is inconsistent. So for example, a patient reports no pain, but is grimacing and guarding their abdomen. We want to validate this information by asking follow-up questions or reassessing. Next is when data is unclear or incomplete. So say the patient says, I take a pill for my heart, but doesn't recall the name or the dose. So then we need to validate by checking medical records and or contacting the pharmacy provider who is ordering that medication to see what pill they are taking for their heart. Anytime you see data outside of a normal range, so for instance, if a patient's blood pressure is usually fairly low, and for some reason this time it's high. Well, we want to double check that, redo another blood pressure just to verify that we heard it correctly. And there's nothing wrong with that. Next is when there are discrepancies between sources. So say a patient says that they follow a low sodium diet, but then the family goes, well, they frequently go to fast food restaurants. So this we would want to validate and explore the patient's dietary understanding. We can collect a 24-hour recall and see what their typical meals, et cetera, look like. And then whenever you have doubts as a nurse, so reading or observation seems to be off or inconsistent with that patient's condition, we can reassess or really seek a second opinion. That's okay. So how do we validate data? So one, we can reassess the patient, repeat their assessment, vital signs, etc. If something doesn't seem right to you or you're questioning it, just check it again. That's not a problem. And then ask clarifying questions if needed. So when we ask clarifying questions, we want to make sure that we utilize open-ended questions. So for example, can you describe that pain again? And then they have that open-ended question to provide a response. Next, you want to verify with another nurse or provider if needed. Additionally, you can verify with the EHR, which is your electronic health record, a family member, or even a caregiver. You want to check medical records or diagnostic results for confirmation as well. And then you want to really compare that subjective and objective data for consistency. Does what the patient tell me match what I'm observing? So the purpose of documentation. So first, what is documentation? Documentation is going to be a written or electronic recording of all pertinent data, observations, interventions, and patient responses that occur during the nursing process or during a nursing interaction. This really serves as a legal, professional, and a communication tool that ensures continuity of care and quality of care. So purpose of documentation. First is communication. It really facilitates continuity of care among all healthcare professionals and ensures all members of the healthcare team have accurate and up-to-date information about the patient, their treatment, and progress. Again, it also serves as a legal record. So this is a legal document in cases that maybe a patient is going to dispute what occurred, there's an audit, or if there's an investigation that occurs on the patient's care. We want to also make sure that we have accurate, timely, and objective documentation to provide evidence of the care that is provided. And so this is really the nurse's professional accountability. We also document for quality improvement and safety. This is to monitor and evaluate quality, effectiveness, and safety of the nursing care. Also for reimbursement and financial purposes. So documentation really helps provide proof of care for billing and reimbursement by insurance or healthcare agency. If there's incomplete or missing documentation, that can maybe result in a denied healthcare claim. And then lastly, research and education. So it serves as a source of data for clinical research and nursing education, and it really helps us identify best practices, outcomes, and trends within nursing care. So what types of documentation are there based on when and why it occurs? So we have initial. So the initial documentation happens at the beginning of your care. It provides a comprehensive baseline. It includes a full head-to-toe assessment and a full health history. So think when they're admitted to the hospital, and we have to go through a whole intake screen and ask all the questions. This is where we're going to do a lot of heavy documentation. And then next you have frequent. So this is going to occur at like set intervals. So during a shift, you may have to do Q4 neuro checks. So then this would be a frequent documentation of those Q4 neuro checks. The purpose of this is to really monitor the status and response to different cares throughout a shift. And this includes not only those Q4 neuro checks like I gave an example of, but we're assessing pain levels, vital signs, I's and O's, any type of wound check, mobility, mental status, etc. And then you have a focus. A focus is going to be on a specific problem, or if there's a change or something occurs with the patient's status. So this is to provide documentation of the assessment we're doing and any interventions related to the issue we are seeing. And it really just includes detailing the concern. So what are the guidelines for documentation? So first we need to make sure that it's legible. We only use approved abbreviations. We don't use any medical jargon. We utilize correct grammar and spelling. And then the information that we want to have in there is in the client's words, so you can utilize direct quotes for what the client is saying. We want to use, if we are doing written documentation, permanent ink that's either blue or black. And then how do we document? We want to avoid wordiness, so we utilize pointed phrases. We want to be objective. We want to use or avoid utilizing non-descriptive terms. Normal, good, large, average, small. Well, what is normal? Everyone's perspective of normal is going to be different. And same with good or bad. That's going to look different for every individual. And then large or small. Instead of utilizing those non-descriptive terms, actually measure the wound or whatever you are utilizing that term for and provide the actual dimensions. And then how often should documenting and or charting be completed? It should be completed immediately after you have done the task. So we want to document and or chart right away and with everything we do. Again, if we do not document it, we did not do it. And then lastly is credentials. So when you are signing as a nursing student, you'll use SFNS. It's in the gray box on this slide. That just says that you're a St. Francis nursing student. So I gave an example. If I was going to do my full name, it would be Faith R. Johnson, SFNS. Or if I utilize my initials, you'll utilize your first, middle, and last. So FRJ and then comma SNSF. So these are just some examples of good versus bad documentation. So bad would be appears confused. What we would prefer is the patient was found in the lobby stating, I thought I was at the airport. So appears confused. Well, why did they appear confused to you? And then you can read through these other examples. We need to be very specific. And then documentation errors. So what do we do when we make an error? And it happens, and that's okay. We just need to correct it appropriately. So again, documentation is a legal record, so we need to be very honest. We need to be timely and transparent in our documentation. So if you make an error, I did put an example in that right hand lower corner. We want to put a single line through the error. You do not want to scribble over it. We need to see what you actually wrote and then single line through it. And then you would put error and then your initials, your credentials, the date and the time that you corrected that error. And then you want to do it fairly quickly. So you see that my initial documentation was at 0800. I put a line through and then I put the error and it was timed at 08:1500. And then I put the correct date, the time and whatever the correction was. And then I still signed off FRJ, SF, and S. And we want to always stay, as a reminder, stay factual and objective. And if for some reason the error is going to affect that patient care, we do need to notify a provider if needed. All right, so I do have a few questions in here. So documentation errors. Practice question number 1. What errors can be identified in the picture document? I will give you guys time. You can press pause and select your answers. And the next slide will have the answer. So the answers are A, so there's the incorrect signature. We just have a name. We don't know what, who you are, who is Martin McDonald. B was not correct, so it's grayed out, not legible. This is legible. C, errors are not visible because it is scratched out. There is not a single line through. There's also no date or time of the error correction. So there's date and time of when it was originally done, but not of that error correction. It's also charted in non-military time. We only chart in military time and medical. And then empty space in documentation. We never want to leave an empty space between like that first larger paragraph. There's a space and then it says reported no history of heart disease or hypertension. We don't leave a space there. We need to draw a line through it because otherwise someone could come back in and falsify documentation. And then objective data is missing. So the patient is stating that, they have a sharp pain, what it is rated, but then we did not do any type of objective data collection prior to documenting this. So we want to be able to include subjective and objective data. And then it's not comprehensive. It's not comprehensive because it doesn't include that subjective data. It's not a whole picture of the patient. And again, in the blue box, it says, let's chit chat. So does this documentation paint a full picture of the client? It does not. And then how do you not add too much? That is when we utilize those pointed phrases and we don't do full complete sentences. So then let's move on to nursing informatics. So what is nursing informatics? Nursing informatics really integrates the science of nursing, computer science, and information science. So it's that little triangle trifecta. So this is going to help manage and communicate data, information, knowledge, and wisdom within nursing practice. So what is the overall goal of nursing informatics? It's to improve patient care quality and safety, support clinical decision-making through data and analytics, also to assist in streamlining documentation and communication. We want to facilitate education, research, and evidence-based practice throughout our care, and then enhance workflow efficiency and resource management. So why does informatics matter? So there's 4 breakdowns on this slide. So first you have your electronic health record or an EHR. This really is driven by informatics and it's the foundation of our documentation. So it promotes that continuity of care so everybody is involved, and that also promotes interprofessional communication so that the nursing staff, physical therapy, the provider, dietary can all look in one area and make sure that we are on the same page and have that continuity of care for our patient. Informatics is the driver of how electronic health records are created. And then ultimately, us as a nurse, we need to make sure that we have accurate and timely charting. And then next you have assessment documentation. So as assessment findings are done, they need to go into that EHR. So your vital signs, eyes and O's, your head to toe assessment, any data that you find will go into that EHR. And then really clear communication is going to protect you as the nurse. Because again, what you do needs to be documented. If not, then you did not do it according to that documentation. And informatics plays a role in that EHR and giving us really the opportunity to have clear documentation and timely documentation. And then you have clinical decision support tools. So it's nice because within the EHR, we have built-in alerts, protocols, care pathways to help us guide our patient care. It's going to promote safe care and early detection of any patient issues and concerns. And then informatics also plays a part in our data literacy. So us as nurses, we must interpret patient data utilizing different digital tools. So we're able to look at labs, vitals. Within the EHR, there's going to be trend graphs. So we can see the trend of their blood pressure or certain labs to provide adequate care. And then it also helps prepare students for evidence-based practice. So the more data literacy we have, the more convenient and easier it is to do evidence-based practice and research. So next is legal implications in nursing. So legal terms to know: negligence. This is failing to take proper care, and that leads to harm. Malpractice, that is going to be a professional negligence that causes an injury. You also have confidentiality. That is the duty to protect patient information and keep it private. And then assault. Assault is when threatening to touch a client without their consent, whereas battery is the actual physical touching a client without their consent. Even if it's meant to help, it can be considered battery. And then you have false imprisonment. That's restraining a client or a patient without legal reason. So I'd make sure I know these terms. So legal implications, we have what we call our torts. These are civil wrongful acts or omissions of care made against a person or property. So intentional tort, that is a deliberate act. You intentionally, deliberately know you're doing it. That's going to be assault and battery. You have quasi-intentional tort that may not intend to cause harm, but it does. So invasion of privacy, breaking HIPAA, defamation, slander. Unintentional tort is the person is harmed and the person inflicting harm knew or should have known the actions were less than acceptable within their scope and standard of practice. That's negligent malpractice. So unintentional is an accident, intentional is on purpose, and quasi is your gossip or disclosure. So then throughout this, there's these red circles. Try to go through them and see which ones you think are unintentional, intentional, or quasi-tort. Looking at legal implications, there's three areas that we look at. We have state nurse practice acts, we have scope and standards of nursing care, and then the code of ethics for nursing practice. So state nurse practice acts, that outlines what the nurse can and cannot do. The State Board of Nursing creates these acts, and it really shows the legal responsibilities and sets those boundaries in the role as a nurse. Then you have scope and standards of nursing care. So this is going to be the national framework that is by and created by the ANA. So the scope is what we are expected to do as nurses, whereas the standards is that professional expectation on how to perform duties. So this is really going to provide us as a nurse the blueprint for safe, competent, ethical, and quality nursing care. And then you have the Code of Ethics for Nursing Practice. This is another national framework created by the ANA. It outlines those ethical principles. So it helps us as nurses guide our behaviors and decision making, and then it helps us act with integrity, compassion, and respect. On the legal side of nursing, we also have federal statutes that we must follow regarding the care for our patients. So there's several of them outlined here. So the Affordable Care Act that provides affordable health care coverage, it increases access to care for the community. And then you have the Emergency Medical Treatment and Active Labor Act. So this prohibits transfers of patients from a private to a public hospital without appropriate screening and stabilization. So that hospital needs to have appropriate screening, and then they have to stabilize that patient before a transfer can occur. And then you have HIPAA. So that's your Health Insurance Portability and Accountability Act. So this provides a framework of the rights for our patients, and it helps protect us as employees. And that's really going to be when you hear about not sharing data and sharing information about our patients to the wrong people. And then you have Health Information Technology Act. That is where patient information, again, aligns with HIPAA, cannot be spread, but this is more looking at the social media side. Then you have the ADA, which is the Americans with Disability Act, and that is going to help protect the rights of those that have disabilities. So we need to follow that. You have your Mental Health and Addiction Equity Act. And so that's going to look at that mental health, providing adequate care for those that have mental illness and also maybe have an addiction. And so it provides competent care for them. Then you have Patient Self-Determination Act. So these are your advanced directives, the ability for the patient to refuse their care because they are really able to self-determine how they want to be treated and what goes on. Then you have your Uniform Anatomical Gift Act. So this is the foundation for organ donation. And then Omnibus Budget Reconciliation Act. This is going to focus on more your older adults. Are we giving them quality care? What's their quality of life and what environment are they in? So really those red bolded ones are going to be the ones that you see quite frequently. And you will hear a lot talked about with HIPAA, ADA, and then that Patient Self-Determination Act. Then you have your state statutes. So we kind of talked about those nurse practice acts. Those are those state laws created by the state's Board of Nursing. And then it really outlines the legal responsibilities of a nurse. Then you have, so then who's the State Board of Nursing? The State Board of Nursing helps regulate nursing practice within each state. They're the ones that are going to issue your license. They're going to enforce laws, enforce any reprimands, and set those standards for nurses. And then you have your healthcare acts and informed consent. These are laws that protect clients' rights. Clients must understand and agree to care before it's given. So this is when you need to have a patient sign informed consent before a procedure or surgery, before they receive blood. You have Good Samaritan laws. So this is going to help protect you as a nurse if there's an emergency that happens outside of work. You must act within that scope of practice as a nurse and in good faith when you're out in the community. Public health laws. So this is going to help promote health, prevent illness, and control any diseases within the public. And it's going to be more on your community side, but you also, as in the hospital, need to report if you have certain outbreaks. So again, this is mandatory reporting, isolation, enforcing, and immunization laws. And then you have the Uniform Determination of Death. So this is a legal definition of what death across all states is. So it's really important for issues when it comes to end-of-life care, organ donation, what that determination of death truly is. And then you have nursing workforce guidelines. So these are those key practice topics. So you have staffing and nurse to patient ratio. You're going to hear about this a lot. Really, we want to have adequate staffing to ensure patient safety, reduce any possible medical errors, and support the nurse's well-being. It's just not safe to have too high of a ratio from nurse to patient. So these are going to vary based on state laws, facility policy, and the type of unit. So typically on like an ICU, you'll have a 1-to-1 or a 1-to-2, one nurse per one patient or one nurse to two patients. On more of a med-surg general floor, you could have a 1-to-4 up to like a 1-to-6, and it's just going to depend. Your night shift, you may have like a higher ratio than during a day shift. And then you have nursing assignments. So these are assignments that must be within the nurse's scope of practice and their competency level. And we're going to look at, when we're making nursing assignments, patient acuity, the experience of that nurse, what available supports available to the patient and the staff, and then that workload balance. So nurses are really in charge of clarifying as well with these nursing assignments, any unclear orders or report unsafe situations to their supervisors. Patient abandonment. So this occurs when a nurse is going to terminate that nurse-patient relationship without any proper handoff or reasonable notice. It's not considered abandonment if the nurse refuses an unsafe assignment before accepting responsibility. So when you come into the beginning of your shift and you see that you're going to have 8 patients, and you know at your facility it is a 1-to-4 ratio. Well, that's double the, your actual required ratio, and that's unsafe. So if you refuse before you take on the responsibility of those patients, that's not considered abandonment. It's also not considered abandonment if you leave after notifying a supervisor and ensuring that there is a continuity of care. So you cannot just in the middle of your shift decide, I don't feel good, I'm going to go home and leave. You have to make sure that you notify your supervisor and that you give appropriate care handoff to the other nurses or nurse that's going to be caring for your patients. If you do have patient abandonment, or if patient abandonment does occur, then you will have disciplinary action and potential licensure suspension occur. Also, nursing students. So you as a student, you'll provide care under the supervision of the faculty member or the preceptor that you're with. Legally, the nursing program and the instructor, which would be like myself, they are going to be the ones to ensure responsibility for safe student practices. So you must practice also within your educational preparation and skill competency. So if you've not been taught a certain skill, then you should not be utilizing your clinical time to be practicing on a patient, because you do need to learn the appropriate steps first. You also then have nurse delegation. So delegation involves transferring a task, but not the accountability. So the nurse is always going to remain responsible for the outcome and the accountability of doing those tasks. When we delegate, there are 5 rights to delegation. So we need to make sure that we are delegating a right task. So we cannot have, at least in the state of Illinois, we cannot have the CNA or the PCT, the patient care tech, who does not have a nursing license, administer our medications. That is not a right task. Instead, maybe we need a Q2 turn a patient, and a PCT or a CNA would be able to do that because that is within their scope of practice, and I am able to transfer that task to them. You then have right circumstance. So is it an appropriate circumstance and situation to do this? Then you have the right person. Are you delegating to another PCT? Are you delegating to a PCT, maybe another nurse? How are you delegating that and to whom? Also, right direction or communications. So we need to provide appropriate communication with the person that we are delegating to. And then, of course, the right supervision and evaluation. Because ultimately, us as the nurse, we are going to be accountable for the tasks that the person we delegate to does. All right, if you have any questions about data and legal implication nursing, please feel free to reach out to me.